So I am, by clinical training, a hematologist-oncologist. I am actually, by research training, a bioinformatician, but have focused in the last 20 years almost exclusively on clinical informatics. Most of the area I work in is secondary use of clinical data for health improvement, quality measurement, and systems optimization. And the context in which I do most of that work these days is the PEDSnet network, about which I'm sure you've heard a lot, and for which I help run the data operation. Sorry about that. So I am happy to have the opportunity to talk to everybody about informatics and how it might operate in learning health systems and learning health system networks. Hanya is also on the call. She co-directs the Data Coordinating Center for the network. And I think both of us would be happy for this to be a really informal and interactive session, rather than listening to my increasingly hoarse voice droning on at you for 90 minutes. Please feel free to interrupt, start conversations, tell us what doesn't make sense, and we will be happy to engage. I'm going to try to encourage that by having deliberately prepared a short set of slides, and then for the back end of the session, we've gotten permission from one of our prior researchers to share with you the feasibility requests that we executed for one of his studies, so that we can talk through some of the details of what that process looks like and how that might go into the project that that you're developing. Okay, so with that in mind, let's go ahead and move forward. I want to start with the most important point in the entire talk, and that's acknowledging that what we're talking about here, as we all know, is not my work or PEDSnet's work or any of our work, but really it is the ability to make use of the information that patients and the people who take care of them have entrusted to us. And making use of that information takes a cast of at least hundreds, if not thousands. So I wanted to at least call out the people who were closest to the slides that you're going to see in terms of both gathering the data and making it useful in PEDSnet, and then taking the data that's come into PEDSnet and actually making it something that can be used as a substrate for study. I'm going to go back then to talking about data science and informatics. And data science.
Charlie,
Yep.
Are you projecting your screen? I'm not seeing it.
I am. Well, that's not good. Let's try this again then. Do folks see my screen now? See, it's great that someone will speak up and tell me this.
No screen. We just see our faces.
Share again. How's that?
There you
go. Now it works.
Okay. Well, good. I'm glad someone pointed that out on the acknowledgement slide, because I do think it's important to note folks who are here. Okay. Sorry. I will try not to be too hoarse. I will also note just the other person who's here on the call, Hanya, whom I think everybody has met, but she's also a clinical informatician with a public health background and helps to run the Pediatrics Data Network, so feel free to direct any questions to her as well. All right, I want to start generally, picking up where Chris left off, with the topic of data science, which is, I think, the Rorschach blot, or a Rorschach blot term in the world of informatics. I look at this Rorschach blot all the time, and I'm curious, what do people see here?
Chameleon walking over rocks.
Definitely a spine.
Anybody else?
Two butterflies.
Butterflies. I like it. So I'm going to show you how weirded out informatics and medicine have made me. Every time I see this, I look at this and say, oh, it's a brainstem. And then I have to sort of take a step back, and I get the chameleon, I get the butterflies, I could even see the British Royal crest here, but it's all about what you see. And Chris talked a little bit about this last time, that data science really is this broad term that covers really anything that touches on how one goes about using data in order to reason in a valid way. It's often used in the context of big data or large-scale studies, and that certainly is a very popular area of application now. But the the process is something I think we're all familiar with in a smaller scale. It's just a question of how to apply this consistently and systematically. It covers a variety of disciplines. I've pointed out a handful here that are sort of core to the field of data science, but you don't need a certificate in data science to practice it. The only thing that I think we all want is if you practice it well. So let's talk about what goes into good data science. I mean, the fundamental thing here is, and the fundamental principle underpinning learning health systems is this notion that we're here to keep learning all the time, and that the entire purpose of the system is to get us to the point where we can learn more and understand more. All right, extra bonus points for figuring out where the quote is from. I'll give you pictures for pointers. Oh, somebody's got to guess. No quiet room.
No clue.
No. So this is Ibn Sina, right? One of the sort of leading minds in developing medical science in the Middle East. Shows up in Western literature as Avicenna a lot, just as a translation of the name. Okay, so we're all here to always keep learning. How do we do that with data? Let's start by thinking about where our data comes from, right? We're going to talk most today about data that's coming out of health systems, and in particular, since it's 2020 and we're 12 years out from ERA and a lot of dollars driving change in the US, we're going to talk about data coming out of electronic health records. I will point out that people have been using administrative data for several decades, and that's a good thing because it really has been our entry into the ability to survey populations in ways that we were unable to do until recently through operational data. It's also a bad thing because we have, we are all creatures of habit, and we have developed a worldview that is very shaped by administrative data. And so in some ways, we are used to thinking of the claims as reality. Part of what we're trying to do now is advance data science to be able to deal with the much messier but much richer operational data that come out of EHRs. That said, the hospital is not the only place that health happens or illness happens, and it's not the only place that information happens. We'll want to think, when we're thinking about a learning health system, about at least 4 other sources of data. So registries are high on the list. I won't talk about them much because Chris talked about them a bit in the last session. But by registry, we basically mean any system that is designed to collect data around some organizing principle that is different from just the delivery of healthcare. Some registries are very tailored to purpose. Some registries are fairly broad. Historically, registries have been founded with a particular purpose in mind and have reflected that purpose very closely in their operation. I think one of the things that ARC is leading the way on is an understanding that highly effective registries are actually tools that pool information and that pool engagement around particular topics. And it's actually counterproductive to try to tailor your registry very closely to the question that you want to answer most or you're funded to answer most. But I will leave most of that discussion to different sessions. Person-reported data, I think, is something that is being increasingly recognized. So for a long time in the world of clinical and epidemiologic research, the least reliable source of data was considered the patient. And in general, we tried to do our best to get the data out of the patient and into a more reliable form, whether that be the health system or that be a structured data capture instrument or that be somebody's interpretation of the patient's experience. We're doing better and better at understanding how the person as the sort of individual who primarily experiences their health, it is a uniquely positioned source of information about that. and a unique source of engagement as well. We are doing much better at being able to get meaningful data into the process of research in a way that meets the goals for standardization and reproducibility, but that tries to reduce the amount of third-party interpretation that sits between the person experiencing health and the person analyzing health. We are sort of just scratching the surface on effective use of passively captured data. In the health system world, there are a variety of ways that these data are collected. Everybody's favorite experience, if you happen to take care of patients, is to be around patients where data is being passively collected by monitors. And our principal experience of that passive data collection is hordes of useless and meaningless alarms. Those, of course, feed forward into the data that we have as well. And so part of the effective use of passively captured data is understanding where the scale of data encaptures meaning as well. And finally, I'll mention area level data, data that reflects the environment in which we live and that reflects some of the determinants of our health that are not individual autonomous and that can be linked to biological or psychosocial or health system data for a broader understanding of patient health. Right? So there's a wide field out there. These are not the only 5 options, but I'm going to call them out as options you are likely to spend more time linking in the conduct of learning health systems research today than you are other sources. You notice that I've referenced omic data and I haven't said much about it. That's again not because it's a small contributor, but because it is a contributor to a particular type of research. So it's subset data like physiologic measurement data, critical for those studies, not used in every study. All right. Talked about data from a variety of sources. How do we get that data to the place that we want to use it? So let's talk about linking of data from multiple sources. Okay. In particular, I want to talk about 3 kinds of linkage. And I'm going to start by saying that if you've read papers on linkage or you've looked at linkage, you will often hear people talking about 2 kinds of linkage, deterministic and probabilistic. We'll talk about them in a minute, but set that aside and let's talk about where the linkage is coming from. So fundamentally, what linkage is trying to do is ask, if I have 2 collections of information, how do I know what data in each of those collections is talking about the same thing? The same patient, the same practice, the same system, same entity. Right? There are fundamentally 2 ways to approach that. The first is to ask, do I have identifiers on both sides of the fence? So are there pieces of data that are unique to, let's say, a person, to simplify the discussion, that I can just connect across those 2 sources? And the easiest way to think about doing that is if I have 2 sets of, say, health service or a health service and registry data, you both have things like patients' names, patients' birth dates, patients' social security numbers, right? So just trying to connect those 2 things is called clear text linkage. But what it means is that you've got to share those identifiers. So if I have some data from CHOP and you have some data from Nemours and we want to link them, then we have to let each other know who's seen at health systems. And when we link those data, we will know who got seen in the other place. So you can understand that from both the patient and the system perspective, that's the sort of thing that people view with some anxiety. That makes it practical for smaller cohorts. It can be done in the large, but the privacy risks and the regulatory overhead rapidly get large once you move beyond the point where you can you can feasibly ask people to participate in this kind of linkage. So the large-scale context where it has been used have mostly been in the public health and disease surveillance space. At the other end of the spectrum is what's called fact-based linkage. So linkage that tries to connect to data sets without any use of data that outside those data sets you would think of as identifying. No names, no dates, no medical record numbers, nothing like that. It simply takes advantage of the fact that there is a difference between identification and anonymity. Right? So you can have a data set that is nominally de-identified. It has none of the things we think of as identifiers. But because there is probably only one person who saw a gastroenterologist on May the 3rd and then a rheumatologist on May the 21st and then went to surgery on June the 2nd. If both sets of data have visit information that includes specialty or even ideally includes provider identity, you can link those data just as effectively as if you'd had names. It actually turns out that if you're trying to link health system to claims data, the study was done in Medicare, it actually takes 3 of those events. So 3 dates of visits with the NPI of a provider, and you can effectively link people across the data sets without any shared identifiers. I'll mention again later, this doesn't always operate in the way that you think it should, right? So I'll give you a great example in the learning health paradigm. So the government of Melbourne, Australia thought it would be great to encourage learning health science. And so what they did was they took their Medicaid equivalent data, fully de-identified it, and posted it on the excuse me, the Department of Health website, encouraging people to download it and look for ways to improve healthcare. And a science team at the University of Melbourne turned around and promptly re-identified all the providers and sent that information back and said, look, based on patient flow patterns, here's who's seeing patients in your system. And after some conversation about that, sort of went back to the data and promptly re-identified or not promptly, but with a little effort, re-identified a substantial fraction of the patients. Because when you publish things like people's lab results or prescription data, you rapidly get to effective fact-based linkage to publicly available sources. In the middle sits this thing called privacy protecting record linkage. Was someone starting to ask a question? Nope. Okay. So in the middle sits this technique called privacy protecting or privacy preserving record linkage, which we'll talk a bit about in a minute. I did say I would come back to the question of deterministic versus probabilistic. And I want to mention them because they're parts of conversations. The easy translation is deterministic linkage is a fancy way to say exact match, right? Probabilistic linkage is a fancy way to say anything else, right? So a deterministic linkage is a linkage based on an identifier that is sufficiently reliable that you think there isn't a lot of question about it, and they match identically across the two sets. Once you move away from that, you're making guesses, and some guesses are really good. If someone spells my first name C-A-H-R-L-E-S instead of C-H-A-R-L-E-S, you're still relatively confident that it's my name, because C-A-H-R-L-E-S is not a common name. It's one letter transposition, and it's a common error, right? On the other hand, if someone completely gets my first name scrambled or substitutes it in, then having things like my last name and my date of birth and my sex become much less effective, right? So it depends hugely on what the two data sets are, but having a last name, a date of birth, and a sex could get you down to a point where matching on those 3 items is only about 50% likely to be an actual personal match, right? So once you get off into the realm of probabilistic linkage, the cliff can be pretty steep. All right, let's talk about PPRL. There we go. So the whole idea behind privacy preserving or privacy protecting record linkage is that, not sure you can see my cursor, but what you can do is convert the kinds of identifiers that we could take outside to the phone book or employment records or any other source and identify the patient in ways we'd rather not, into things that we can't use anywhere else. And we use standard encryption techniques, the same things that you use when you get on a website and communicate with your bank or your doctor or something like that. Then it's those hash data, the encrypted bit strings, that are compared to see if they're linked, if they're identical, in order to establish linkage. What that means is that you can try to link data from 2 groups without ever actually sharing the identity of people who belong to the other group. All that you need to share is that those people match from one side to the other. Now, if there's a match to somebody at Nemours and I know their name at CHOP, I will know who the patient is at Nemours, but that's not me discovering an identity. That's just me discovering a linkage. Right? So this is pretty simple in concept, although it can get kind of hairy in its implementation. but because it's maybe not something you bump into all the time, let me stop and ask, is this something anybody has run into before?
I've not seen anything like this before, but I had a, despite the credit, that's really funny. Never seen that before either. But
Just be toned, by the way.
Do you have individuals? I guess, do you have people positioned within the healthcare like blue box and people like within the in like the other set of data to encrypt it, to link it? Like, I guess who's responsible on each side of the source to match that up?
Sure. So the way we do this is that in each blue box, there is somebody who is responsible for taking the known identifiers, the names, the addresses, the dates of birth, and encrypting them. And then when they're done, they take the encrypted data and they put it in a box and walk away, right? And then there's another person who sits between the two in the white space here, who takes the encrypted data out of those two boxes and establishes the linkage. So what that means is that the person who knew the names never knows who linked, and the person who knows who linked never knew the names. So we use that kind of an airlock mechanism, again, to try to reduce the risk to individuals' identities. Okay, so this is a system that takes a little bit of work to set up, but it's actually becoming easier and easier to do. First of all, because a lot of the work is in getting it started, and once you've done it the first time, it's much easier to do the second. And second of all, because it's a growth industry and there are lots of startups who would be happy to help you do this. I call it out because as people get more and more sophisticated in assessing the risks of clear text linkage, it's becoming less and less acceptable to ship around large lists of names or insurance identification numbers and things like that. And this is going to become, I think, for all of us, more of a sort of common denominator in the way that we try to do linkage when we're moving outside the boundaries of single health systems or single bodies that know the identities of patients. I will say that the reaction to this, from the research side is generally fairly positive, with maybe a little bit of annoyance at the overhead. I will also say, and again, you folks may have talked about this in previous discussions, the reaction on the patient side can also be fairly mixed, with the strongest negative reactions to this that I have heard are sort of frustration among highly motivated patients and family members that there has to be more overhead between getting the data that they see as critical to answering questions about themselves or their kids into the hands of people who can answer those questions. But what this does do is assuage a lot of institutional risk about the business liability associated with linkage. Okay, so moving on, let's talk a little bit about fact-based linkage. Okay, see if there we go. So I pointed out that this was most useful in cases where there aren't identifiers available. You can often do a better job, particularly you will expect to do a better job in the space of negative controls when you have PPRL available to you, right? So I bring it here partly because it is useful when you don't have identifiers or for some regulatory reason can't move forward with PPRL, right? And I bring it forward because I do want to reiterate that because this is identifier independent, it means it is a risk inherent in any data set. And that's why we make the claim, certainly in PEDSnet and in a lot of sort of large-scale informatics and data science communities, that there really is no such thing as a de-identified data set. That term is meaningful from a regulatory perspective, but I would encourage you to be very careful about data that describes individuals, whether or not it has their name attached to it. a little bit about how this works. What I do want to say is it can be remarkably effective. So this is a summary of linkage between about 22,000 patients admitted to the ICU at CHOP and 23,000 and 22,000 patients known to a multi-PICU collaborative known as the Virtual PICU, right, VPS, who abstract data about patients. This was conducted with no information about the patient. So by Adam Zornig here at CHOP, who was blinded to the identities of patients on both sides and used only things like vital sign and laboratory measurements to try to link the data. Right? So what he's doing is using a method that looks at the information content of each of these data elements and then tries to line up similarities in those data elements across different patients. And I'm skipping most of the detail of the method. What I will say is that the x-axis represents effectively a linkage score, and the y-axis represents the fraction of linkable patients that you actually link. Right? So if you go back and unblind yourself and ask who should have linked, what you see here is your sensitivity, your specificity, and your predictive value here, and it's clear that you can, with setting the appropriate score cutoff, relink in the right cohorts of patients the huge majority of people you need to study without any use of identifiers. Use that effectively, use it for good. Okay, so having said that, let's talk a little bit about regulatory oversight of data use and of informatics, particularly in the US. And I'm going to talk about two pillars here. One is HIPAA, and the second is the common rule. And I call it the common rule and friends because, as you may know, either from sessions elsewhere or from having sat through research ethics training, the common rule applies to a number of federal agencies, but it doesn't apply to a significant minority, including the FDA. They have a separate set of rules, although it does track the common rule closely. So we'll talk about these two today. The distinction I want to make is HIPAA is a statute and set of regulations that deals primarily with managing data about people who have health insurance and providers of health services via health insurance. It deals with, in relevant part here, the privacy of healthcare data. It doesn't particularly contemplate research. It is not limited to research as a use, but it deals with data sharing. And it has a very black and white view of what constitutes identity risk, and that has to do with whether certain identifiers are not present. The common rule, which is the framework in which the ethics of research take on their statutory and regulatory structure, has a different standard for managing privacy risk, and that's the concept of readily identifiable data. So there are no lists of identifiers. There are no rules that say if you have a name, you cross this threshold. It is this broader standard of whether a person who looked at this data could, from the data, say, oh, I know that person, right? And what constitutes readily and not readily is a bit in the eye of the beholder. All right, so let's talk about HIPAA first. And I'm going to talk about the privacy rule in particular. The first thing I should say is that HIPAA turns on this notion of protected health information, or PHI, and the simple statement is, if there is PHI present, then you need the patient's permission to use the data. Right? That can be waived by a privacy board, and there are some particular statutory waivers, but in general, you need the patient's permission. Right? It ranks the risk based on whether or not there are specific identifiers present. So from a HIPAA perspective, the most permissive level is something called de-identified. And you know why I have that in scare quotes there, right? When data meets the HIPAA threshold for de-identification, then it's not regulated. The privacy rule is done, and you should use the data using your best judgment. Right? There are two ways to certify a data set as de-identified. The first is called expert determination, and that basically says that somebody who knows what they're doing looks at the data and says there is no reasonable risk that if somebody got their hands on this data, they could identify an individual. That's all the expert determination rule says, and the Office of Civil Rights in HHS, which administers HIPAA and writes the privacy regulations, has very carefully declined to say anything else about expert determination in order to allow some room for experts to function. So one predictable result of that is it is fairly rarely used. Much more common, the sort of de-identified for the rest of us standard is the so-called safe harbor rules. That's that list you're familiar with of 18 magic identifiers, and if your data doesn't have any of those 18 magic identifiers, then it's considered de-identified, right? Just remember that number 18 is anything else that might identify the patient. So you can't get to a safe harbor data set by looking at it and saying, yep, no names, no addresses, no medical record numbers, no photographs, no IP addresses, no, right? You have to think about whether there is anything else in the data that someone might use to identify the patient. I will also say that that is almost never useful in pediatrics because one of the things that you cannot have in a safe harbor data set is a date. In particular, you can't have anything more granular than a year. And so you can miss a fair amount of physiological and psychological development with the granularity of dates there. And so we fairly rarely do data on de-identified data or on safe harbor data. At the other end of the spectrum, according to the privacy rule, are fully identified data. And the answer there to data sharing is you need permission, or you need a privacy board to say that you couldn't get permission, right? Or you need a BAA, a business associate agreement with the people you are sharing the data with that encompasses a number of restrictions on how they use the data. In the middle is this concept called a limited data set, right? So it is safe harbor data, except that you can have dates, right? Except that that anything else clause goes away, and that's huge. And except that you can have locations up to the level of a zip or a census tract, right? So this allows you to get a lot more done, right? Once you have dates, you can create accurate ages, you can create accurate intervals. With zip level data, you can connect to a lot of meaningful area level data, right? So this middle level is created to try to facilitate use of data that has not no, but limited risk to identity. From a regulatory perspective, you still need permission to use it, but the restrictions are now encapsulated in this notion called a data use agreement, which is much less restrictive than a business associate agreement. Some of you may have had experience trying to set up DUAs across institutions. It can still be a little laborious because the rule here is telling you what's needed to protect patient privacy. It's not telling you what's needed to protect the business interests of each institution. And so cross-institutional negotiations often involve that as well. I will point out just in passing, by the way, that the privacy rule doesn't say you need a DUA when you share data across covered entities. It says you need a DUA when you share data, right? So if you have data that you've collected for a study and one of your colleagues in the same institution is going to use that data secondarily for another study, then according to the privacy rule, you need a DUA with that person that sets out how they're going to use the data and what the limitations on that data use are. Most people don't get audited, but do remember that. It doesn't have to be a huge informal document, but there does have to be some indication of what the data sharing is about. Okay, let's talk about the common rule a little. So as folks know, the common rule, which is the rule that gives life to IRBs and that IRBs administer, has a whole comprehensive approach to the ethical regulation of research. Excuse me. As it applies to data, however, there are a couple of things that you want to think about. The first is when the common rule thinks about privacy for individuals, the standard, as I said, is readily identifiable, not could possibly be identified. And that's something you want to keep in mind, right? In particular, in the minds of most people and most IRBs, if you have data that you could use to go back into your EHR and re-identify the patient, it is not readily identifiable when you share it with me because I can't get into your EHR to identify the patient. The other thing to bear in mind is that when you talk about risk to people under the common rule, that definition of risk is fairly broad. So you're talking about not just physical risk, but you're also talking about psychological risk, emotional risk, social risk, reputational risk, economic risk, right? And that becomes important because there is a significantly reduced regulatory burden for studies that fall into the category of minimal risk, meaning that the likelihood that something would happen is very small, and if something happened, the amount of harm it could do to someone is also very small. Significantly, how we address secondary use of clinical data has always been a topic of a lot of common conversation under the Common Rule. And there was a fair diversity in the way different organizations addressed it. What the 2018 revision to the Common Rule makes much more clear is that secondary use of clinical data, unless you do something really dumb, is sort of definitionally minimal risk. I mean, you are not free, obviously, to take all the HIV results from your institution and post them on a public website. I'm not saying it's impossible, but I am saying that the revised rule is much clearer that it is harder to attribute risk other than a data breach to secondary use of clinical data. Whereas there was a lot of conversation previously about whether there was risk to patients because there might be reputational harm because the researchers would see things and so on. So what does that mean in practice? It means that there are some things that you want to think about when you're doing the kinds of research that are common in a learning health system program or environment. The first thing to note is both HIPAA and the Common Rule contain explicit exceptions for taking care of your patients, for responding to public health emergencies, and for responding to regulatory needs, such as the FDA requesting information about drug safety or things like that. So these things, because these things can figure much more prominently in the kinds of operational learning and operational improvement, I thought it was worth calling that out. When you're doing LHS-style research, there are some particular things you want to take away from the 2018 update to the Common Rule. Have you folks gone through this in another context, or is this the first time we're talking about it?
Charlie, John touched upon some of this in his talk, in his regulatory talk, but not in great detail.
Okay, then I'll try to be really quick about this. I mean, if you look at this slide and you look at like Category 4, Category 5, Category 7 exemptions, is this all old news? I'm seeing some heads shaking. Okay, we'll talk through it really quickly. So there are a couple of things that are significant, right? First of all, there is a strong preference for single IRBs now. So the Common Rule is trying to move away from the model in which everybody submits to their own IRB and studies kind of drift a little bit because everybody has their own requirements. Given the frequency with which you'll do multi-institutional studies, think about that early on, right? Second of all, the category of exempt research. So research that the IRB reviews, checks is being done safely, but then does not further oversee has been expanded. And there are in particular 3 new categories in addition to expansions of existing categories for things like behavioral health and educational research, right? Secondary use research is now categorically exempt. That's a change. It used to be that it was exempt only if you didn't have identifiers. So anybody who's done a chart review study under the old rule is used to getting expedited IRB review for that because it was identified. Now those research are exempt. And so they are subject to what are called limited IRB review, where basically the IRB is not asking, is the science valid? Do you need these data elements? Could you do it some other way? The IRB is asking, are you going to keep the data safe? And if you are, we're done. There is a new category for agency-supervised program research. So it used to be that if a federal agency conducted program research, so research on the effectiveness of Medicaid, early intervention, Head Start, prescription support, that sort of stuff, then it was exempt. Now, agency-sponsored or agency-supervised research in these areas is exempt as well. So if a study is intended to assess the effectiveness of a community outreach program or a Medicaid expansion or things like that, then it may be exempt because of its programmatic focus if it is funded by a federal agency, even if it is investigator supervised. The third exemption, which I sort of put in a different color here because I think it's a little early to call it in practice, is that there is now provision for what's called a secondary use consent, or the regulation calls it a broad consent. So under the old rule, a patient had to consent to every use of their data, which maximizes transparency, but also makes it very difficult to do later research on long-term outcomes or follow-up or things like that, because that was not contemplated when the patient first enrolled in a biobanking protocol or a clinical trial. So there is now the option of a broad consent under which a patient can, when they enroll in the trial, say, oh, and it's okay if someone who comes along 5 years later and wants to do a different subset analysis or wants to do a long-term outcome analysis uses my data. We're going to have to see how those consents get written into informed consent documents, and it'll take a while before we get to the use for those, but bear in mind that they're out there. Two other changes. Continuing review is not required for any minimal risk research, whether it's exempt or expedited. And consent forms are changed so that they are more participant friendly. They are less a compendium of contractual language that makes the institutions happy, and they need to be intelligible to the people who are actually giving their consent. All right, I'm going to limit the regulatory conversation there, and let's go back to talking about data. So let's talk about, from the health system's perspective, getting the data you need. I think things are changing, but I have certainly, in my limited time in the, if not ivory, at least brick tower, seeing more studies not done because the thought is there's no way we can get at that data. So I'm going to pause again. Anyone want to try to identify this speaker? See, the sad news is by putting her picture there, I've limited the set of people whose quotations were written down so much that this has to be easier for you. Give it a shot. I can't go on until somebody takes a guess.
Clearly, none of us are very good at trivia.
Clara Barton.
Near miss, Florence Nightingale, but you were so close, so close. It's a pity that the stereotyping is so easy, but yes, Florence Nightingale. So talking about, excuse me, the difficulty of getting things done in India under the British Raj. Okay. Please advance. So let's talk about data structure and trying to get to the data that you need. I want you to think about data along two axes for a minute here, right? So the y-axis here is what I call discreteness. It's how clearly did somebody record the piece of information you need, as opposed to what's the likelihood that there's a gem that you need, but it is in the midst of a great big pile of rocks, right? The other axis I want to think about is how clear is the definition? If I said it and you said it, how likely is it that we said the same thing? Or how likely is it that we said something that sounds really different, but was intended to mean the same thing? That becomes a really significant factor when you're talking about trying to analyze data at scale, because computers are very fast, but they're also really dumb. And so we're used to thinking about things in a very associative way. One of the folks here, Bob Grunmeyer, who I think Chris quoted in his last talk, another of the clinical informaticians, just on a lark one day, pulled all of the primary care visit notes for one 24-hour period in the CHOP network and asked, how many different ways could we find for someone to say this kid had a fever, right? And we all know what that means. And we would all read the notes and understand that there are 102 ways to say that. And some of them sounded similar to each other, fever and febrile. Some of them sounded nothing like each other, fever and temperature, fever and tactile, warm and elevated, things like that. Those are things computers have a really hard time with. All right. So what we want to do is spend our time up here in the upper right-hand corner of this graph, where the data are both discrete and we can get a handle on what it is we want to know, and they're standard, so we all say it the same way. So that's a dream, right? The place we'd like to live is somewhere in the middle of the graph, preferably a little to the right and a little above the axis, where things are present. They may be text, but it's a limited vocabulary. They may not be precise, but the words are similar. It's not that hard to tell the difference between fever and febrile, between LRI and lower respiratory, right? The problem is all too much data lives down here. We are creatures of narrative. We love to write things in notes. We love to say it's in the note, buddy, go look it up. And we all know how hard that is, how hard that makes doing research at scale. And so we will talk about how that factors into design of research. Right? Where do we put the data? How is the data preserved? Chris talked about common data models in his last talk, and I'm going to advert to them quickly because they're a really important tool. They're an important tool for large multinational or national collaboratives like Odyssey, a couple billion people across multiple continents, CoreNet, about 70 million people, we think, in the United States, ResDac, so everybody who's covered by Medicare in the US, not a whole lot of kids, so I won't spend a lot of time there, and on and on. But they are also useful anytime you get beyond a single study or a single investigator. Right? To be a common data model, though, you need to have three things. You need to be common, so we need to agree on how we're going to do it, and the data needs to be interoperable. They need to address data, not just ideas. It needs to get concrete, and it needs to define how the data are going to be stored. And we actually need a model. We need specifications that make sense and that tell you where to put stuff. So remember on Saturday, I sent out to all of you the information about PEDSnet data, and there were two charts. There were two documents there, right? There was a one-page document that had some graphs and some connections on it, not designed to induce seizures, but to sort of tell you what data are in there and how they connect. That's a common data architecture, but if I handed that to somebody and said, could you put your data here, there would be no way they would know how to represent the data or where to put it. The common data model was that 56-page document that I sent you that tells you for each piece of information, here's the slot you put it, okay? So I am a huge fan of common data models. Think about them early, think about them often, think about them together. When you do that, one of the things you want to ask yourself is, how do you say what you mean, right? So someone says, I want to study a patient's hemoglobin. Well, that's your hemoglobin. How many of you are likely to want to walk up to that with a scanning electron microscope and ask, okay, so what's going on with your hemoglobin? That is the definitive way to tell whether somebody has sickle cell trait or sickle cell disease or not, right? But we label this in a way that's more compact and more accessible. We just need to be careful about the distance between the label and the truth, right? The perfect common data model are the people who are in states of health, but we can't scan all of that information. Despite the very nice ads from IBM and other people that show people walking around their daily lives with these trails of digits coming from them. So we want to be careful about the labels, right? What are the labels? Well, here, and actually I started talking about hemoglobin, this is factor 8. Here are common labels for particular conformations or states of this molecule, right? But the fact is, the person walks in the door with that molecule. No one ever walks into your clinic with a 286.0 stamped on their forehead. That is not what it means to have hemophilia A, right? And neither, if you go into data and say, I want everybody with a 286.0, will you get the people who have hemophilia A. You'll get the people that somebody put a 286.0 in front of. So the question is, how do we describe that and how do we use those terms? The question also becomes, how do we connect those terms, right? So here are a variety of different ways to talk about hemophilia A, right? These are all taken from a nomenclature or terminology called SNOMED-CT that puts a lot of effort into trying to connect these things in a way that would allow you to say, you know, I just want to know what people said about hemophilia A. And that would be equivalent to saying, tell me anybody who said any of these things. Doesn't tell you if it's true or not, but it at least allows you to systematically approach what people were talking about. Okay. Or let's think about the drug you use to treat hemophilia A, right? So leaving aside eculizumab, these are different ways to talk about, purified factor, right? So you can see that there are at least 5 brand names. They come in different strengths. They're all parts of antihemophilic factor. This is an easy example, right? Because if I wanted all of them, I would only be looking for 5 brands. If I wanted to know who got amoxicillin, I'd be looking for about 4,500 terms, right? And it's really hard to try to figure that out. So you want to be able to use standard terminologies in a way that lets you say, I'd like to know who got amoxicillin, and lets the terminology do the work of figuring out what are the variety of ways you can say that. Okay. I'm going to skip past this to talk about what happens when we don't have those kind of terminologies handy. So remember I mentioned that there are 102 ways to say fever. Here's another simple task. Whose ears were normal and whose ears were not? So it's a little snippet of code that is designed just to take pieces of physical exams and figure out what a normal ear exam looked like. Okay? It would be much easier, obviously, if we were up on the discrete end of that spectrum and someone just said normal, but we don't, right? Or we may say normal left ear or left ear normal, or things like that, right? So it takes this kind of work to figure out what's going on if you don't have good discrete data. That doesn't mean that it's never useful. It just means be careful when you sort of head down this path and ask yourself, are there other ways you can get to what you want? Because this is going to have to deal with a lot of representational diversity, and it's going to have to deal with a lot of risk of overtraining to what the things you knew about included that may not be represented in the notes you weren't looking at. For all of that, you can get good data back from this, of course, right? So 25% of the visits where there was a diagnosis of otitis have normal ear exams, according to this kind of person. So the question is, does that mean that those kids didn't actually have otitis and the exam was, the code was a rule out or a test of cure code? Or does that mean the patient actually had otitis and we are all so used to just pulling a templated exam into our note that we don't bother to make sure that the patient's medical record actually reflects the patient? In some cases, it may be that there just isn't a good discrete place to put this. So I'm showing you summary data here from another study looking at adolescent health behaviors, right? And if you look at the number of times that the provider checked a diagnosis that reflected sexual activity or a discrete data element that reflected sexual activity, high risk, low risk, or otherwise, we could have identified information for about 2,000 patients out of a set of, I want to say, in this case, about 23,000. If you look at the text, you can, you can over triple that, right? Depression screening is even starker, right? We should be screening patients routinely for depression. If we look for evidence in the EHR of a structured survey, so a risk instrument, we found a total of 17 patients. Now, granted, this was back in 2016. Hopefully, it's a little better now, but I'm not betting. But if you look in the provider notes, then 44,000 patients actually had somebody ask them, are you okay, right? But if you wanted to do a study of depression and you said, okay, I know where I can get that, I can get it in the discrete data, you would end up with huge misclassification. All right, so that's discreteness of data. Let's talk about how you use the data.
Charlie, can I ask a question that comes up a lot before you get into phenotyping? Give you a chance to express your voice a little bit as well. Most pediatric institutions now are using the EPIC electronic health record software. And EPIC has a transactional database, and then it dumps those data into its Clarity data warehouse. Mm-hmm. Why can't institutions just pull their EPIC data and combine their EPIC data? Why not just use EPIC's data model as opposed to using in PEDSnet? Why do we use the Odyssey common data model? What's going on there? Why not just pull, say, here are the 20 fields in EPIC that we all want to combine, pull them, and it's EPIC, right? So you should just be able to combine it. What are the limitations there?
Yeah, so I think there are a handful of major limitations. Two of the biggest are, first of all, that EPIC doesn't when they sell their EHR product, create any sort of real terminology standardization. So what that means is that a diagnosis of pneumonia is coded in the EPIC that's at CHOP completely differently from the coding in the Epic that's at Nemours or at Boston or at Colorado. They're not related in any way. That's designed to make the system as flexible as possible for each hospital to implement, but it means that there's no commonality. And so in order to get to some commonality, you need to back up enough that you can get to one of those standard terminologies. Sometimes that's relatively easy. So when you talk about prescriptions, the point of prescriptions is to send that information out to a pharmacy so they can give the patient the medication. And at some point, you have to talk in a language that more than CHOP understands. In some cases, it can be really difficult. When you're talking about a measurement like a vital sign or a Z-score or something like that, there may be no shared terminology between institutions until you get to the common data model. It's also in different places, right? So the second issue is we may choose to represent it differently. So for some sites, this information may be one of those little drop-down lists that appears in a note. For another site, it may be on a flow sheet somewhere. For a third site, it may be in a questionnaire, which Epic calls a smart form. And those data are stored in different formats in very different places in the EHR. So any attempt to share across Epic sites is effectively an exercise in creating a common data model. The goal, I would say, is to create a reusable common data model. And Epic is trying this too. That's what their Cosmos initiative is about. Rather than trying to create a common data model that works only for one study.
Great, thanks.
Cool. All right, so let's talk about phenotyping. A couple of things to say about phenotyping. Fundamentally, phenotyping is looking for the footprint of the event that you're after. Because nobody walks in the door with a 286 on their forehead, you want to know what is it that distinguishes these patients from other patients, right? What that means is often we need to think outside the code. We need to think about what else is available. This is one of the places where operational data like EHRs can be much more complicated and much messier, but also much stronger than the kind of administrative data we're used to working with, where we don't think outside the code because we can't. It's all the data that we have available. Doesn't mean you can't cross-validate. It just means that your universe of data is more limited, right? So here's a classic example. So what we did was we went through the EHR, we looked at actual measured heights and weights and figured out who was obese. And then we went back and said, okay, how often did the provider actually record that in the EHR? And what you can see is that outside of weight management clinics, no one got it right more than 27% of the time. So if you tried to do a study of obesity using administrative data, you would, on the way in the door, misclassify 70% of your obese patients, right? So when you phenotype those patients, diagnosis codes is not a great way to do it, right? What you want to ask yourself is, what do you want from your phenotype? How can you get there? What are the kinds of data that you can use? How replicable is that? Am I training a phenotype that takes advantage of a flow sheet row that the endocrine clinic at CHOP uses reliably for all of the patients with diabetes, but it won't work anywhere else in the world? Am I using a phenotype that is less ideal in its operating characteristics, but could expand to any Epic site or to some Epic sites or to all of my collaborators? And then how are you going to validate that? How do you get the face validity? How do you internally validate it for reasonableness of the construct? And how do you externally validate it? Are there gold standards out there at all? Okay. The last thing you want to think about is how computable is this phenotype? Can you get the information you want at scale, or is it actually going to require manual review? Again, what you want to ask yourself is how much do you want to accept problems of either sensitivity or specificity? So what I'm doing here is looking at a population of patients who have IBD, and I'm asking what proportion of those patients have one diagnosis, two diagnoses in one drug, two diagnoses in two drugs, right? And what you can see here is that the number of patients who get one diagnosis and nothing else is way above the number of patients who get even two diagnoses. And it turns out most of the patients in the one diagnosis only category don't have IBD, right? They carry that diagnosis, but it was suspected, possible, rule out, I need to get a colonoscopy, you name it, right? And so what you can do is, as you move out on the curve, get to a point where you preserve reasonable performance, but it's not the majority of people who have the code. In fact, what you can do is tune your computable phenotype to match the needs of your study. If what you needed was to screen people and catch everybody for, say, a surveillance purpose, but you didn't care if you got it wrong most of the time, then you might pick one diagnosis, accept a significant hit to your specificity, but know you're going to get all your cases, right? If you wanted a high positive predictive value, you don't have the ability to survey the entire population, but you want your hits to be very likely to be positive, then you want to move to the right down the curve. And you just have to ask yourself, what's the penalty I'm willing to accept with respect to sensitivity? Again, knowing that that sensitivity penalty is not level, the patients that you're losing in sensitivity are disproportionately likely to be more recently diagnosed or require less intervention. So again, if you're studying a therapeutic intervention, that may be more tolerable. If you're trying to recruit patients early to for an intervention that tries to prevent disease progression, that may be less tolerable.
How do you obtain the truth or the gold standard to calculate this?
So in this case, we took advantage of, we went back to the program. This is a single site figure, and we went back to the program and asked, okay, here are the people we're talking about. Can you tell us who actually has Crohn's disease? So think of it as effectively chart review here as the standard against which we calculate. Whenever we create a computable phenotype, we will do some sort of external validation against the registry, against medical records, just to see how we're doing.
So there's a necessary step of external validation when it comes to quality of your data model?
I think so we're talking about the phenotype here, and it depends on what you have available for internal validation, right? So if you have, for instance, a diagnosis treatment pair that are highly specific, you may be able to get good internal validation by looking at construct validity. Does the presence of the diagnosis lead to the outcome that you expected? Right? It may be that you don't have that available, and then you have to go to some external source, and perhaps you have a registry available. If not, then you may have to do something like medical records review.
This is a really important point. It's a great question. Charlie laid out some of the approaches, but another approach, in addition to chart reviews and looking at how the variables relate to one another, is to compute rates, for example, disease rates, and that ought to line up with some other measure of disease rates. Say, if you're interested in the epidemiology of Crohn's disease, does what you compute in your health system, recognizing that it's a referral population and the rate's going to be a little bit higher than a general population, do they align with what the CDC has produced? And so I think all three, that internal assessment, the chart review, what you might call classification accuracy, and then contrasting your data with external data are all important. And this computable phenotyping, Charlie's hitting on, I just want to emphasize, it's really important to get a grasp on this for any kind of work that uses electronic health record, whether it's defining a population, it's defining your comparator groups, or defining your outcomes. It's all phenotypic expressions of some clinical variable, and knowing how to do good computable phenotyping is essential.
This is, in many cases, as important, in the worst cases, more important than getting your modeling right. Right? There's the axiom in the data world: garbage in, garbage out, and that is definitely not the study design you want to pick. All right, so to that point,
before you get to your third trivia slide, I just want to point out one thing, and because Charlie just mentioned it, but I want to elaborate on it because I think it's something that people who grow up in an epidemiological or health services tradition need to realize, and that is, when you do, say, a study using a national survey, like the National Survey of Child Health or the National Health Interview Survey, or et cetera, you're getting a highly curated data set that's already been through a number of data checks. And also the data quality is assured because they tend to be interviewer administered type surveys. When you're using data that's collected for clinical care and then is turned into data sets that are used for analytic purposes, you're really you really need to pay an enormous amount of attention to how your analytic data set is constructed. And that is an area that gets overlooked time and again. It's actually a big area of research interest for Charlie and Hanya, how you evaluate the quality of the data. And so I just want to point out that part of what we hope you get from this program is an understanding not only that the EHR data can be used for research, but to go well beyond that and understand that if you're going to do one of these projects, you're going to have to figure out how to translate clinical concepts into expressions. And this is why we're having you do your data projects over the next several weeks. We really want you to sink your teeth into this so you have a much better understanding of when to phone up a data scientist to get their assistance with this kind of database construction and then the analysis of some of these data sets, as well as to understand what some of the limitations are as you start to read the literature. So sorry for the interruption, Charlie.
That is a perfect setup for where we're going. All right, so next historical quote. This time I'm making it easier even because this is a famous picture, not just a well-known historical figure, but a famous picture. And guesses?
Saying to know your something.
Yeah. So I'm measuring. Nothing autan would be the quote of his. I'm paraphrasing a little bit, so nothing de dominasas, but does that help you at all?
Socrates?
Yep. I carefully edited the cup of hemlock out so it wasn't too easy. Right? Okay, so we got one positive here. Right? So the key here is knowing your data. Right? One of the keys is that effective learning health research means that you should not be trying to customize your data collection to your study. If you're doing that, then that's creating a systemic failure, right? Because what that means is that you're limiting the potential for cycling of knowledge. Doesn't mean that we should not be changing the system to make it possible to collect better data. It's just not a retail operation, right? So when you think about your data, we want you to think about data quality assessment in 3 levels, what we call structural, semantic, and fitness assessment. So structural assessment are the kinds of things you're used to thinking about. Are the data present? Are they coded right? Are they numbers when they should be numbers? Are they positive when they should be positive? Things like that. Semantic data quality says, okay, if it's there, is it meaningful, right? I mean, I may have a weight. That weight may, the data model may say it's weight in kilograms, and I get a weight back of 3,400. That patient never weighed 3,400 kilograms. So that may be a structural data quality success, but it is a semantic data quality failure, right? And in particular, there is a branch of semantic data quality that asks not just are the data meaningful, but can the data answer the questions I need them to answer if I'm going to conduct this study, right? And so you want to think carefully about how to do that, because as Chris said, one of the keys in secondary use data research is that the data come to you as they are. They may be very high quality data. We put a lot of effort as healthcare systems into QCing the analyzers we run labs on. Turns out we do a pretty good job of measuring heights and weights. They may be terrible quality data. They may be gappy. They may be things that are missing. They may be things that were obtained in the wrong setting, right? So I will say that systematic testing across data sets and data networks helps. So one of the most effective things you can do, as Chris said, is connect with a network. Connect with a national survey, connect with a research network, because we're doing things all the time. So what you look at here, and this is old data, but it reflects trends that hold up, is that as time goes by, the number of errors that are in the data that are due to fixable problems, so programming errors, or what we call ETL errors, goes down because we get better at it, right? So regular systematic testing is important. It's important to report out on specific data as well. So you're looking at something very simple here. Can we tell what specialty a patient was seen in? If you have a study design that says, I'm interested in kidney disease diagnosed by a nephrologist, or I'm interested in someone's assessment of sepsis if they're a critical care physician, then you need to know, can you get at these data? That carries forward to semantic data. So what you're looking at here is several million measurements of height and weight across a large cohort of patients in PEDSnet. And in particular, what you want to see is there are a bunch of categories that don't have a whole lot of numbers in them, that are labeled with not very intelligible labels, but are fancy ways to talk about implausible values. The place where most of the errors appear are in the first two categories, where somebody's just duplicated the prior value. So it is certainly quite possible to bias your analysis with that, because now you have the expectation that the patient's height or weight was true at an age when it wasn't. But those are the kind of things that will skate right by structural checks that are designed to eliminate implausible values. Right? So there is a system to this as well, right? What you want to do is think about this in a way that marries what you want to do with the data, those pink squares in the upper left. What's the context? Where are you getting your data? What do they mean? With the best practices that exist in the field of informatics. I'm echoing somewhere, I'm sorry. The best practices that exist in the field of informatics for assessing data quality, those squares up in the blue. Put them together to get to a considered assessment of how you might look at your data and how you might assess the quality you need, and that will create for you a set of very concrete data quality checks. As Chris says, this is when you pick up the phone and call a data scientist. We'll help you think about this, right? We'll help you think about it like this, right? We're going to say, how do you want to analyze the data? What kind of data are present, and how are they dependent on each other? Which ones are really important to you, and which ones are sort of covariates that you're kind of interested in but might not be central to your analysis? And what do you need to know, right? What are the things that will change your study design, or that could let you remediate data? And those are the things that we use to get to data quality. Right? So what does that look like? What you want to do is account for.
Chuck?
Go ahead.
Oh no, I was going to say, Chuck, I think you're echoing. Can you mute? Or I think that's where the feedback is coming. Okay, thank you.
You want to look for key characteristics of the analyses that you're conducting, and come up with an alignment between your data quality testing and the requirements of the study. That's what fitness encompasses. So here's an example from a large study of antibiotic prescribing and its impact on weight. So what we did was we looked at whether prescribing rates reflected expectation across a variety of health systems here. And we looked at that for our main exposure, antibiotics, and for a covariate, steroids. Each dot here is a different health system. And what you can see is there's actually pretty poor correlation between errors in or deviations from expectation in antibiotic prescribing and in steroid prescribing, probably because we capture those data in different settings. Right? So you can't just say prescription data are good or bad. You have to ask, how are they good or bad? It doesn't easily get better as you get bigger, right? As your cohort size increased, it was not clear that there was some correlation, but it was not clear that your data were going to get better. Right? So what you end up with can be a fairly maybe off-putting initial measure, but a fairly inclusive measure of data quality across a number of domains. Here we're looking at primary exposure, antibiotics, covariate exposure, steroids and anti-reflux medications, primary outcomes, heights and weights, but also accounting for silent errors like the duplication as opposed to outliers. Right? And you come up with a composite measure of data quality that you can then apply to a variety of data sources and relatively readily identify places where your analysis may be significantly skewed, or that may actually pull your analysis if done in aggregate in a particular direction. You want to understand why those things differ, and in particular, you want to understand whether they're inaccuracies or whether they're accurate, but if you include them, they may just lead to results that are more or less generalizable. You can do this in multiple contexts, and what I want you to understand is that you can do it in a study-specific way with a fair amount of flexibility. So what you're seeing here are data quality scores across 3 different quality measures, right? Looking at antibiotics for otitis media, metabolic screening for patients on antipsychotics, or transcranial Dopplers for patients who have sickle cell disease. And you will see that the different health systems show up in different places. So it's not just a matter of good quality data or bad quality data. How the data align with the task or the analysis that you want to conduct gets to be important. Okay, so I talked about thinking beyond the code. I want to talk a little bit then about the potential of direct measurement here, and I'm trying to make this easier and easier. This time I even put the person's name in the photo, so you just have to be able to read somebody's scrawl. Here's the quote. Anyone? Anyone? Only for the sake of time will we move on. It's Antonio Spasalia, so prolific Renaissance anatomist. When he's talking about more than one or two observations, remember that this is dissection of unembalmed cadavers. So there's a bit more involved in accumulating those observations. But I do want to point out that one of the things that operational data like EHRs bring to you is the potential for direct measurement. So Chris talked about national survey data, right? The gold standard in the US for anthropometrics, for weight, height, and BMI is the National Health and Nutrition Estimation Survey, or Evaluation Survey, NHANES, right? That is very, very carefully curated data. It has, on average, per month of age, 18 measurements. Right? If you look at PEDSnet, until you get into the older teens, we have, on average, per month of age, about 6,000 measurements. So one of the questions is, if you have that, does the breadth of the data operate to damp down any of the noise in measurement? If it's random noise, then it will likely help you. If it's non-random noise, it may or may not, right? What you can see is across sites, the BMI curves, or the ECDF for BMI, in this case, there's not a growth curve, but an ECDF, line up very nicely. And if you compare estimates based on the EHR data to the NHANES data, I think Chris showed a quick summary of this last time as well. The major difference between the two is that when you've got 5,000 to 6,000 points per month of age, there's nowhere near as much hysteresis as when you have 18 points. Now, that's not to say that any large healthcare data set that measures things thousands of times is going to be better than survey data. It's just worth noting that the value of primary measurement is something you need to consider in study design, both with respect to other sources of primary measurement and with respect to clinician conclusions, right? So what do you want to do? You want to review your metrics carefully. You want to ask yourself, how am I defining things? So you're looking here at evaluable visits for height velocity across a study when you use different definitions of what interval there has to be between visits in order to measure height velocity. And you can see that you can pick up a substantial number of visits just by moving the boundaries of your evaluation interval out a little bit. Right? You can get most of your time back from just going back 2 months and out 3 months, which is physiologically not a major factor in measuring height. Be careful when you pick your boundaries. Don't do this a priori. Use the data, right? Same thing happens for weight loss. Right? See what you can then add, right? So as you get information back about data cleaning, how many visits do you get back, right? So let's pick examples like abdominal exam data. Prior to cleaning, I'm a little allergic to the term cleaning, but to understanding how the data behave, you can only evaluate that for 44% of visits. Once you know how the data behave, you've got it for almost everybody. Ditto for symptoms and so on, right? Ask yourself what your outcomes look like, right? So how does a clinician's impression of things line up with the impression that objective measurement gives you? It may be that one or the other is better. I'm not arguing that objective measurement is necessarily the right answer. Both of these are measures of severity of Crohn's disease. You can see they correlate actually quite well with each other. One is based on things like height velocity and lab values as opposed to clinician impression. There may be domains where one is going to be so clearly epistatic to the other that you want to follow clinician judgment because it's integrated, or you want to follow objective measurement because it's reliable. When you're doing that, ask yourself how close you are, right? So The PCDAI, the Pediatric Crohn's Disease Activity Index, I'm following through the same study, is an 11-element index of Crohn's disease severity, right? So if you ask yourself how many kids had all 11 of those data, it was 20%. So if the place you start is, let's do a complete case analysis, you've just lost 80% of your population, and you've just lost the generality that you get with that, right? That doesn't, when you do complete case analyses, you will get purer data on the people you analyze and the inability to say anything about the people you didn't analyze. Right? On the other hand, if you back down by a couple components, you rapidly get to the majority of your population. And if you look at imputation, so in each of these tiers, the left box is the subset of patients for whom all 11 elements were present. And then each of the right boxes are different imputation methods. And you can get operating characteristics from imputation that are extremely close to the observed population. Don't throw away 80% of your population when a little bit of work with the data can get you a much more generalizable study. This is the study, I'm walking through this because this is the study that Chris presented the results of in his last talk. Also think about how you can get to better data, right? How do you get to active data capture that people are willing to collect for you? A lot of that has to do with engagement. We engage people around altruism most of the time. Gee, it would be really nice. You're my friend. I'm doing a study. Can you record this data for me? You may also want to think about mutual benefit, right? If you get to the point of care, do you have more raters? Can you build that in? What's the benefit to the person who is collecting your data? How can they help you to streamline the data collection? Again, from the same study, here's the form that was subsequently moved into the EHR to collect information on patients routinely at visits. The form is now adopted at more than 80% of visits, and that's partly because people are interested in the data, but it's partly because when you fill out the form, it writes your note. It sends the letter for you. It tells you whether you need to think about adding disease control medications and gives you that prompt, that sort of stuff. So it gives you enough feedback that it's worth your time. All right, so bottom line, what am I saying? I'm saying that we are going to have to live with gray areas, and I'm going to give you a couple more chances to climb out of the hole on identifying people. So we're getting closer to the present, closer to home. Who's this?
Osler?
Osler, yes. All right, we got a second one. This is William Osler. Science of uncertainty and an art of probability. Do not go into your studies or into your data with the notion that if it's not perfect, it's useless. Right? But clearly, we don't want black boxes. Right? We're not saying that some magic happened and an uninterpretable transformation away. Here are my results. Right? So what I'm inviting you to do is pick a road, pick the more or the less traveled road. We actually found a yellow wood for this picture. Right? And think about things like adding data science to the research tool set, right, alongside trial design and modeling, right? Because it's not about designing the study to spend however much money it takes to go out there and get perfect data. It's about using the data for the most representative number of people that will reach across the greatest disparities to reach the most valid conclusions, right? Think about how we add data science to clinical practice, right? We all need to move beyond the I know my patients, it's in my note, right? And to how can we share information? How can we learn more? How can we get better at taking care of the patients, right? Ask ourselves when we need to know the absolute cleanest efficacy or when we need to be pragmatic and ask how effective is this going to be in actual practice, right? And as you well know, I'm preaching to the choir, think about learning as a collaborative effort, not just my note, my study, my grant. Okay, so that's it for slides, and I want to thank folks for their time. If anybody wants to stay around a little bit, I had said I would spend some time going through a pragmatic example of what the feasibility study might look like. I've got about 15 minutes that we could spend doing that if folks can stay. I kind of leave it up to you, and I'd also be happy to take any questions.
I have another meeting I have to go to, so I can't stay. But just one question I have is if there's some example language that you could send around that, whether it's been for a grant or an SOP or something you've read in a manuscript about describing the method where you would say this is an exemplary data quality, that assessment that that we read or reviewed, and you would want reflected in the kind of text that we do in some of this work.
Okay, I think we can do that. Sure.
Should oh, go ahead, Chuck.
I was gonna say, I did a little bit of informatics classes as part of a master's, and one of the things that's really striking is this idea, and you just presented it really well here, how any piece of data within your database you're looking at or your EHR is totally different. And if you try to take like all the data from all the EHRs and connect them together, how impossible like that would be around a single variable, just because of all the different ways you could describe it and making things interoperable. But I've also heard when they talk about like our election systems, the fact that everything's so decentralized is an extra layer of security, right? So the fact that everything is so different would make it hard for any one person to, from a security standpoint, really influence things in a meaningful way. From the data standpoint, I'm not sure what it's like in other countries where they have like a centralized health system. I mean, is there any truth to that, or is that just something that we say because it makes us feel better about how complicated things are?
Yeah, I think it's, with respect to heterogeneity of data, it is probably more us comforting ourselves. With respect to the ability for affecting one control point to break a lot of processes, there's truth to that, right? And what you find is that if you look at countries that have good centralized record keeping, what we often see are results of epidemiologic studies that come out similarly to the ones that are done in, say, the US. They're just done with a lot more effort. So there's probably not a whole, by using, for instance, a single coding system or that sort of approach, there's not a whole lot of evidence that what you're doing is causing people to code to the system and skewing results. Whether there's a small bias could be really hard to assess there. None of these systems have single control points in a way that makes it very easy to actually, from a security perspective, affect the provision of care. Does that make any sense?
Yeah, thank you.
Sure. Well, I think we're losing a lot of folks. Okay, so it may be then that what I can do is send out the documentation from the feasibility query, and folks who want to get together and talk about it, I'm happy to meet.
That's great, Charlie. Yeah, no, that's great. Thank you so much. I think you set up a really great foundation, a lot of really good questions to think about, especially as we dive into the project and thinking about the specification. So thank you so much for your time, Charlie. Thanks, everyone, for joining.
All right, happy to join.
Thank you. Bye-bye.
Participating.